This systolic ejection murmur, heard at the third left intercostal space, is the right ventricular outflow murmur of Tetralogy of Fallot. The large ventricular septal defect, shown here, does not produce a murmur because the pressures are equal in both ventricles. Listen once again to the murmur of Tetralogy of Fallot. Tetralogy of Fallot consists of four components: subpulmonic stenosis, ventricular septal defect, an overriding aorta, and right ventricular hypertrophy. This disease is the most common cause of cyanotic heart disease after infancy. What is unusual about this ejection murmur is that its intensity and duration are inversely related to the amount of obstruction across the pulmonic outflow tract. As the obstruction increases, the murmur becomes shorter, softer, and peaks earlier in systole, reflecting decreased pulmonary flow, while the large ventricular septal defect allows more shunting of blood to the left ventricle. Over the last 3 decades, advances in surgical treatment have dramatically improved the survival of patients with Tetralogy of Fallot. In fact, survival to age 30 has increased from 6% to 86% for those with successful operative repair. A repair of Tetralogy of Fallot includes a patch closure of the ventricular septal defect, resection of subpulmonic obstruction, and placement of a transannular patch across the pulmonary valve. For many patients, this transannular patch results in pulmonic regurgitation. In addition, many patients will have both a systolic murmur of residual stenosis as well as the diastolic murmur of regurgitation. Listen to the combined murmurs of pulmonic stenosis and regurgitation. I will start with the systolic murmur and then add the diastolic murmur. Following surgical repair, some patients may have a pansystolic murmur at the lower left sternal border due to a residual septal defect around the patch. Listen to the sound of a small residual ventricular septal defect. Patients with repaired Tetralogy of Fallot are at risk for sudden death, which accounts for 70% of late deaths. Several studies have shown that when the QRS approaches 180 milliseconds, patients have an increased risk of ventricular tachycardia. Listen once again to combined pulmonic stenosis and regurgitation.